Good evening, everyone, and welcome back to our plenary session, which is going to be our third session today, and it's going to be on spondyloarthritis. We are honored to invite Professor Dr. Ahmed, convener and president, Pakistan Society of Rheumatology, and Professor Wajahat Aziz, former head of Department Rheumatology at PIMS Islamabad, to chair this session, along with Dr. Shazia Zamurad, Associate Professor, Department of Rheumatology at PIMS Islamabad, as co-chair. May I request our esteemed chairs to kindly join us on stage.
For our next keynote speaker, we have Professor Ahmed Abogamal, Professor at Al Zahra Hospital, Dubai, UAE. Today he'll be presenting on Beyond Inflammation in Psoriatic Arthritis, Interleukin-17 Inhibition, and Bone Preservation. His talk is sponsored by Novartis Pharma. Please join me in warmly welcoming Sir.
Okay, Bismillahirrahmanirrahim. Assalamu alaikum. I'm happy to be here and thanks for the PCR for accommodating me in their program. And as already introduced, my talk will be covering the psoriatic arthritis from the concept of IL-17 inhibition towards the bone preservation. It's my disclosure, and here if you can see this picture, old picture here representing the teaching hall of Al-Azhar University. Has been opened 970. It has been more than 1,000 now opened. So if you have been in Cairo one time, please have a look on this teaching hall. It's pointer, okay, thank you. The story of my talk will covering 3 segments. One of them will start with the psoriatic arthritis and how it's affecting the bone itself, by what and how, with another segment covering the 17 inhibition in general and its impact on the bone, with focusing on CQ on bone outcomes. Psoriasis is almost a prevalent autoimmune condition covering almost 2 to 3% of the population, with 1/3 of those patients could have what's called the psoriatic arthritis. And psoriatic arthritis, to affect the bone, there is 2 already possible pathways. One of them come from what's called the upstream pathway in immunology, which are already totally dependent on the interaction of the dendritic cells. The dendritic cells is the primary cells that happening in psoriatic psoriatic disease that drive the activation of the autoimmunity toward activation the T lymphocytes. Activations could happen by 2 different sets for differentiation toward either T helper 17 or T helper 1 through interleukin 12 and 23 activation, that ending by secretion of the abundant inflammatory cytokines, ranging from interleukin 1, rankel, and 17, and TNF-alpha, which is the famous cytokines affecting the different lesion of the psoriatic disease. The step next is about activations of some cells in the connective tissue, ranging from the osteoblast, osteoclast, chondrocytes, and the endothelial cells with keratinocytes, with the subsequent unique combination of lesion in psoriatic disease, from the osteoproliferation in one side and bone resorption and destruction in another side, with a mix of synovitis, tenosynovitis, with the extra-articular manifestations. So there is a unique already characteristics in the psoriatic disease by bone destruction and erosion on one side, and at the same time there is a signal of bone formations and repair. This is story happening, as I said, on the upstream level, but if we go to the incisions or incitus level, what's happening there? By one of the most famous role model of incisions, which is the Achilles tendon. At the Achilles tendon, we have the biggest fibrocartilaginous incisions, and here we have residing undifferentiated cells, which is the gamma delta T cells, that usually respond to some mechanical stresses by releasing the interleukin 17 as the initial signal of inflammation at the level of the incisions. By 17 release at the interstitial level, it comes with vasodilatations or increased vascularity on the subcortical bone areas, with infiltration of the incisions organ by the polymorph nuclear lymphocytes. After that comes to the second step, with locally release of TNF-alpha, followed by activation of the osteoclastogenesis and osteoclast, by bone resorption, and ending by bone formation stimulation through osteoblasts. So again, we have two different mechanisms ending by stimulating both the bone formation and the bone resorption, which is a unique characteristic for spondyloarthritis and psoriatic in specific cases. To summarize this, we have two important inflammatory cytokines, 17 and the TNF-alpha, acting mainly through the Rankel ligand at the level of the bone. At the bone level, we have what's called the stem cells that already is the origin or mother cells of the osteoblast and the osteoclast. And here, both of the three, the 17, TNF-alpha, and the Rankel can already direct the stem cells towards the differentiation towards the pre-osteoclast. Activation of the pre-osteoclasts is the main issue to start the bone erosions at the interstitial sites or either to the marginal bone areas, which has been also reversed here by the other arm of the bone lesion with psoriatic disease that comes mainly through the 17 cytokine, not the TNF-alpha, that has the ability to stimulate the stem cells' commitment towards the osteoclastogenesis and at the same time can activate the pre-osteoblast to lay down bone and osteoproliferations that already seen on the X-rays as the bone proliferation or spares, either at the interstitial site and also with the mix of bone resorption and bone formations at the articular sites. And we are always seeing this in our clinic by the ultrasound images that for the Achilles tendon, as we can see here, a mix of signal of bone formations and resorption in the same image when scanning the posterior surface of the calcaneus, which uniquely happen and seen especially with psoriatic disease as a marker of both osteoproliferation and bone resorption in the same image. It's already connected and already seen with the different syndromes on the musculoskeletal system with psoriatic disease, either DIB arthritis with osteophytes as the DIBs, or either also seen at the Achilles tendon, also seen with the disabling resorption and destruction of the joint in arthritis mutilans. That's simply the background about the connection between psoriatic disease and the bone, how we already interact with the different sites, either at the upstream level or downstream. Carrying this to the clinical science and applications, how we can see the impact of 17 inhibition towards the bone itself in the psoriatic disease that can already be presented either through the bone turnover markers or in radiographic progression data, and also can be presented through the real-world imaging data. In the bone turnover data, actually, there is independent analysis showing of bone turnover marker has no consistent increase with 17 inhibition. So the actual reversal of the osteoporosis or bone destructions cannot be measured through the bone turnover marker based on the data that we have. But at the level of the fine regulations of the bone cell activity, as we've seen here, by the sclerostin and DTK1, which is one markers representing the Wnt pathway, which is responsible for the osteoproliferation and the bone formations that controls the osteoblastogenesis. 17 inhibition have the ability to normalize the level of sclerostin and DTK1, which inhibit the bone formations, and in another term, that inhibits the osteoproliferation and spare formations in psoriatic disease. Another important aspect for the assessment of the marker, which is the bone mineral density markers, and we have one trial showing that 17 inhibition using the high resolution peripheral quantitative computed CT can increase the bone mineral density after inhibition of 17 by SECU for 24 months, which also indicates this is a good benefit, or at least inhibition of the bone resorption side using the 17 blocker pathway, but again with minimal change or non-significant change in bone turnover markers. Another markers come from the inhibition of 17 blockers by secukinumab by the normalization or reduction of the S100AB and S100A9 in 6 weeks application of secukinumab that already indicated the suppression of inflammation at the level of the joints for synovitis and also for the bone inflammation by the MRI just in 6 weeks with the inhibition. Another evidence comes from the clinical data that we have with the radiographic progression, and radiographic progression in psoriatic disease it has also to be assessed with two different parameters. One of them, which is the negative side, was the bone erosion or bone resorption, and we have the other side, which is osteoproliferation, which is one, as I said, a marker for the psoriatic arthritis or psoriatic disease. Based on the data that we have from Future 1, Future 5, which is the phase 3 trials for secukinumab, the continuous suppression of 17 pathway for 24 weeks or 52 weeks of continuous applications have a significant halting of the disease progression on the radiographs. Up to 90% of patients treated with this two treatment model, either at the same doses, 150 or 300, which showing the beneficial effects of the evident across subgroups with inhibition of the 17 pathway. And this response is not a TNF dependent. So even with previous exposure to TNF pathway, still secukinumab can suppress the radiographic progression on Future 1 and Future 2. In Basartorius' study, which is actually a unique study that studies the interleukin-17 inhibition by secukinumab and assessing both the catabolic side, the erosive, and the anabolic side, the syndesmophyte formation or incisophyte formations by the high-resolution quantitative CT, and there is no progression over the bone erosion and also in the osteophyte formations. But this is the most impressive with this group of patients. We can look here in this MRI. And after treatment, this is a baseline image. This is actually after 24 weeks, we can see the synovitis and as the second and third MCP with significant bone marrow lesions that totally reversed to normal after 24 weeks of 17 inhibition, representing the impact of 17 inhibition pathway on the bone remodeling and also with the inflammatory changes over the bone. At the PREVENT study, which represents the impact of 17 pathway inhibition on the axial, again, we have a significant change on the bone marrow edema lesions in the MRI, especially over the sacroiliac joints, was already shown in over 97% of the patient involved in this trial. Inhibition for 17 blockers with 17 cytokine by another pathway like XZ also have almost a similar data, especially for the SPIRIT head-to-head trial, which compares the 17 inhibition with TNF inhibition in two parallel arms, that showing even 17 blocker pathway could be even more better in controlling the radiographic progression and the inflammation around the joints. Another data coming from the dual 17A and F blockage with bimekizumab and sonelokimab, showing also similar data over the radiographic progression, but persistent data is not yet published due to already the new molecules. In the real world data, we have this very nice trial just published in August this year, which studies the efficacy of secukinumab on the incisophyte and the erosion progression in psoriatic arthritis for 1 year. And it shows that secukinumab could be able to protect against bone erosions. This trial involved the patients with early psoriatic disease, and we can see here from the images that there is almost reversal of the inflammatory signals over the bone and also improvement on the volume of erosions over time, with halting the progression on the osteophyte formations. From the longitudinal data from the real-world registry showing also over 2 years 17 inhibition by 17 blockers, we have significant also clinical and functional improvements. This is the Italian registry showing the progressive improvement on the rate of the remission, which is matched also by halting the radiographic progression. And also we can echo the same signal from the Corvitas cohorts for patient registry from South America, that already correlation between the clinical inhibition of progression, which matched also with the radiographic progression. So on the clinical trials, we have evidence that there is improvement or halting the disease progression at the radiographic level, which already translated on mainly on the decreasing both arms of the disease with bone resorption and also the osteophyte and incisophyte formation, not confirmed on the bone markers, but we have the evidence that correlated mainly with the inflammation and functional ability. For secukinumab, especially with the bones, is the most heavily investigated interleukin-17 blockers, and especially with the connection with the bone itself. As already shown in the previous trials, there's a consistent suppression of bone erosions and at the same time the bone formation, which is unique characteristic in comparison to in TNF-alpha inhibition, and also the functional ability in the trial showing patient achieving the MDA and LDA and the HAQ-DI improvement. Especially this high prevalence among patients have a significant radiographic halting or radiographic non-progressors, which is aligned with the clinical and functional improvement. Another unique also characteristics of CQ in 17 blocking about normalizations of the bone biomarker, especially for the sclerostin and DTK pathway, which already normalize the or halts the progression toward new bone formations and intensophyte formation. And this already presented here with the after 1 year of secukinumab application measured by the quantitative CT. As we can see clearly on the image, this is the baseline image. We can see the volume of erosions assessed by the CT, and the LB was almost reversed over the time after 24 weeks of applications with decreased reduction of the bone marrow edema lesion comparative to this. So with the unique impact of the 17 blocking can reverse the bone damage. Another trial reflecting the impact of early blocking of 17 blockers with the IV PSA trial that including patients with complete criteria of psoriasis with no evidence of psoriatic arthritis on the clinical assessment. Patients should have nail or scalp psoriasis with high psoriasis severity index and the inflammatory lesions or erosive only seen on the MRI and CT with no significant pain or positive clinical assessment. And those patients, after 24 weeks of the application, we can see the reversal of the process on the imaging. As you can see here, the synovitis on the marginal sites here already totally normalized after the application. And we can see the bone marrow edema lesions and synovitis mixed signal here in the STIR image completely resolve it. And again, synovitis of the radiocarpal joint recess totally resolve it in the follow-up images, just to be applied early so we can already reverse the patient towards the normal. What about the other mechanism or improving psoriasis through TNF-alpha inhibitors? And for sure, there is no head-to-head that compares the CQ for such cases, but the analysis showing almost similar response, especially for halting the disease progression towards the catabolic side or bone resorption, while in some analysis by Maximovic showing that achieving SS 20 and 40 could be happening early as 12 weeks in comparison to adalimumab with the secukinumab. And for the radiographic endpoints, the main characteristic as we presented before that interleukin-17 inhibition pathway, so CQ has the ability to stop both arms of the bone effect in psoriatic disease by halting the progression of the intensophyte or bone formations, and at the same time increase the volumetric repair of the bone erosions by inhibition of the osteoclastogenesis and Rankel ligands. This is all my slides, and coming to conclusions that interleukin-17 inhibitors typified by CQ here in this slide established as superior, non-inferior to TNF and the other pathway inhibitors, and the exerted effects through both direct inhibition of osteoclastogenesis and the modulation of bone remodeling pathway, as confirmed by the advanced imaging, especially the QCT. Continued head-to-head studies needed, especially for registry analysis to compare the impact of different pathways in controlling the psoriatic disease and its connection to the bony distractions and in turn by the functional abilities. That's all my slides, and happy to get your questions. Thank you.
Our next speaker is going to be Professor Hasan Tahir, Professor and Consultant Rheumatologist at Royal Free London, NHS Foundation Trust, UK. Today, he will be presenting on Beyond Disease Activity, addressing the challenges of difficult-to-manage axial spondyloarthritis. His talk is also sponsored by Novartis Pharma. Please, everybody, let's welcome Professor Hasan Tahir.
Okay, thank you so much for asking me to give a talk on addressing the challenges of difficult to manage axial SPA. These are my disclosures. So just give you a little overview of axial spondyloarthritis, especially for some of the trainees here. So axial spondyloarthritis is part of the spondyloarthritis family, which causes clearly back pain, stiffness, and fatigue. It's a chronic immune-mediated inflammatory condition which affects the spine and sacroiliac joint. And there are two subsets. One is it's based purely on radiological changes. So on plain x-rays, if you have x-ray changes, you are known as radiographic axial SPA, also termed axial ankylosing spondylitis. And if there's no x-ray changes but MRI changes, we look at calling it non-radiographic axial SPA. This is data from the UK from a recent survey done by NAS. And there's some really interesting points here. So 1 in 200 of the adult population, this is in the United Kingdom, have axial spondyloarthritis. That's twice as many people with MS and Parkinson's disease, which is taught a lot in medical school, and most medical students will know a lot about MS and Parkinson's disease, but interestingly, very few know about axial spondyloarthritis. Onset typically starts late teens, early 20s, the average age is about 26. The key thing is this delay in time to diagnosis of 8.5 years. And depending on which centres you're at, I mean, at our centre, our time to diagnosis is actually under 5 years, having been involved in the whole early diagnosis and time to diagnosis project. 59% of people with axial spondyloarthritis report experiencing mental health, and that is really important, that it's a fundamental aspect of their care that needs to be addressed. And I think that is actually across all of our autoimmune rheumatic diseases, and something that we struggle to manage, because I think that ultimately affects outcomes in most of our chronic conditions. It affects the same numbers of females and males, and I mentioned this in my talk yesterday. Axial spondyloarthritis is not a disease of males. It is equal numbers, 50-50. So just bear that in mind. We know about the HLA-B27 gene, and what is amazing is that over 90% of the UK population have never even heard of axial spondyloarthritis, but 110% of the population have heard of back pain. So everyone knows about back pain. Back pain is so prevalent, but they just don't know about the term or the diagnosis of axial spondyloarthritis. Just a quick recap, you've got your musculoskeletal manifestations and you've got your extra-articular manifestations. Majority of patients will have this inflammatory sounding back pain, pain at rest, better with movement, stiffness, in the mornings, buttock pain, waking them up in the middle of the night. Very different to our mechanical pain, with pain which is better with rest, worse with movement. So very simple discriminators between the two. You'll get dactylitis, you'll get peripheral arthritis, and in our previous talk we talked a lot about enthesitis. You'll be getting the enthesitis as well. You get these extra-articular manifestations. So obviously a lot of us in our history will ask about psoriasis, we'll ask about uveitis, we'll ask about inflammatory bowel disease, and uveitis is one of the most prevalent extra-articular manifestations seen in our axial spondyloarthritis patients as well. In our cohort, we did a study looking at, in the uveitis clinic, looking at the other way around, about 30% of patients actually had undiagnosed inflammatory back pain. In that group of patients. I'm just going to present the NICE guidelines. You have to have failed two anti-inflammatory drugs before we can go into treatment. We have 3 licensed biological mechanism of actions. You have the anti-TNFs, you have the IL-17s, of which there are 5 anti-TNFs, there's 3 IL-17s that we currently have access to, and there are 2 JAK inhibitors, and there'll be a 3rd JAK inhibitor which will become licensed in the United Kingdom. And the idea is that you'll go on one of those. We tend to go towards the cheapest one, which at the moment is adalimumab, and then we will switch. And in my slides to come, I would talk about which agent should you be switching to, whether it should be in the same class or a different class of drugs. Comorbidities is really important in axial spondyloarthritis. I suggested that in my previous slides I mentioned things like uveitis and IBD and psoriasis. But if you look at IBD, you have a prevalence of up to about 14%. And the importance of knowing about IBD is the class of drug that you will be using. You'll be, in someone with IBD, you'd probably avoid a soluble TNF receptor like etanercept. You'll be avoiding an IL-17, so that comorbidity makes a difference. Uveitis, we tend to be using monoclonal antibodies, mainly directed at the anti-TNF in patients with uveitis, and it is very prevalent. And likewise with psoriasis. The challenges that we have in our axial spondyloarthritis patients who are put on biologics are they get uveitis, or they get IBD, or they get psoriasis. Was it as a result of the drug, or is it just part of the disease spectrum itself? And that's quite challenging to work out, and especially with uveitis. You know, when they do get recurrent uveitis, was that because we started them on an anti-TNF? Was it because we put them on an IL-17? Or was it that was their just natural history of their condition itself? Cardiovascular diseases are also really important to bear in mind in all our autoimmune rheumatic diseases, that we have quite a significant proportion of patients which have a high cardiovascular burden. And that becomes important in our patients, again, especially with anti-inflammatories. You know, how frequently should we be using anti-inflammatories? Should we be using it regularly or on a PRM basis as well? Because that has a cardiovascular disease burden as well. And then we talked about osteoporosis. I find osteoporosis quite challenging in my axial spondyloarthritis patients, and how should we assess them? How should we manage them? Because remember, they're a very young cohort of patients, and there are no real guidelines out there on what we should be doing with these patients. The other really important thing, and I really must emphasize, is depression and anxiety. How many of us have the skill to actually identify depression and anxiety? And in the next few slides, I'm going to talk a bit more about that, and there's some really fascinating data out about that. And this is just a thing, the importance of comorbidities, because ultimately it does affect health outcomes in an adverse effect. You get poorer function, reduced quality of life, work productivity, and potentially increased mortality with these associated comorbidities. Biologics are great. You can look at it in two ways. Biologics are fantastic. You know, if we look at real world data, they work in 50% of patients. But actually look at it the other way around. They don't work in 50% of patients. So we look at it on one side, they're great, but they are not great. And that's where we look at there is still a massive unmet need in our patients. Even though they do well, a significant proportion also don't do well on treatment. And I think this slide is really fascinating. We're looking at women. And if you look at in men, non-radiographic and radiographic axial SPA, much the same sort of outcomes, but in women, for some reason, in non-radiographic axial SPA, response to treatment seems to be less favorable than in women who have got ankylosing spondylitis or axial spondyloarthritis. And these are important points to bear in mind when patients don't respond to treatment. So what should you do after you fail your first biologic? The most important thing is make sure you've got the diagnosis right. We talk a lot about time to diagnosis. There's a delay in diagnosis, and we're missing patients. But I think the big problem also is now that we're coming, the terminology delay to diagnosis, we may be over-diagnosing patients as well. And I think this is a really good study that I just want to talk a bit about. This study is called the Improve Axial SPA Project, aimed at assessing the effectiveness of telemedicine support in enhancing basically the diagnostic accuracy of patients with suspected axial SPA. And it took on board clinical and imaging information and multiple centers and up to about 500 cases. So this is local and this is central. So locally, axial SPA was diagnosed, but if we went to the central readers, only 50% of them were correct diagnoses. So potentially over-diagnosing at a local center. Then if we look at those patients who were thought locally not to have axial SPA, there's an agreement of about 85%, but those who thought they weren't, 7% probably did have axial SPA when they felt they didn't have it, and uncertain was that. But the key message here is, look at that, that's big potential concerns about over-diagnoses. Now let's just break that down, and I just want to, so look at that arm there. That's local versus central readers. And if you look at that, the people who got it right tend to be younger patients, and that's what we see. Younger patients have axial spondyloarthritis, and that's why they were getting it right. Those who were getting it wrong were much older patients as well. So just bear that in mind. If your patient who's slightly older is not responding to treatment, have we got it right? Look at the BMI. Those who have got low BMI, you tended to get it right. Those with higher BMIs, potentially there was an error, because we know, and I'll mention this in the next few slides, that patients who are overweight also can have abnormal MRIs and can see bone marrow edema on their sacroiliac joints. If you look at the back pain, those who we got it right, they had back pain for shorter duration of time, and those who we got it wrong were slightly longer. So possibly that as clinicians, we feel, oh, they've had pain for so long, they've got those symptoms, so we're maybe over-diagnosing patients who've had it for a bit longer. And CRP, you tend to find that the CRP tends to be higher in patients who have active disease, who got it right, versus those who haven't got it right as well. So overall conclusion is there's a high risk of overdiagnosing in clinical practice. On one hand, we have those that we are underdiagnosing and we're delaying in diagnosis, but caution is, please let's not overdiagnose patients. And this slide will say, remember in your patients, your MRI is not we don't diagnose axial spondyloarthritis with MRIs. I've had a few conversations with colleagues, in our conference, and the point is, the takeaway message, well, certainly in our clinics, is it's a clinical judgment. We don't diagnose axial SPA on imaging. We base it on a story, on their history. We base it on their examination. We base it on their imaging. We base it on comorbidities and results of investigations. With all that information, that's when we make that diagnosis. We know if we focus on MRIs alone, overweight patients may have abnormal MRIs. You'll get bone marrow edema. We know that marathon runners, army recruits will have these abnormalities as well. Pregnancy, postpartum, don't review a scan which is done within 4 to 6 months of a patient delivering their baby, because you will find abnormalities potentially in the sacroiliac joint. So there is caution in your MRIs, and a diagnosis of axial SPA is not a radiological diagnosis. So what would you do if you fail after your first biologic? Have you got the diagnosis correct? Yes, I think I've got it right. So the next question is there any other explanation for my symptoms? So just remind you about pains. So you've got pain pathways, you've got the nociceptive pathway, which is your classical inflammatory pain. You've got your peripheral, your neuropathic pain, which when you get your burning, tingling sort of pain. But you also have, again, this is not just alone with AS, you have with all our autoimmune diseases, you have your central sensitization, your noisy plastic pathways as well, just to bear that in mind. And basically, the key message that I'm just trying to get here is that if you look at this particular study, what we're looking at in patients with active disease, about 9% of patients will have neuropathic pain. In patients with controlled disease, 27% will still have noisy plastic pain. Your widespread noisy plastic is your fibromyalgic type pains, central sensitization pains. And patients, as I say, with controlled disease, 27% still have noisy plastic pain. And when disease is controlled, noisy plastic pain persists in about 1/3 of our patients. So it's not just about controlling the disease. If they still have pain, why are they still having pain? And that could be that they've actually developed these triggering of the noisy plastic pathways. And when we look at some of you, certainly I do in my clinic when we do the WLI indices, or I'll get them to tick the boxes. So if you look at the pattern, you tend to find this sort of pattern in active disease, whereas this is I got pain all over my spine type pain, which is more in keeping with noisy plastic type of pain. So if you have someone with low disease activity, with low CRP, and they still are not getting better, complaining of pain, the wrong thing to do is let's give them another anti-TNF, let's give them another monoclonal, let's give them another biologic. That is not the thing to do. If you don't believe they have active disease, and this is all about pain pathways, what you should be focusing on, if you think it's a noisy plastic pathway, is what we sort of mentioned before, is focusing on things like supervised exercise program, psychology input, sleep hygiene, and medication as well is what you should be really looking at. So once you've confirmed it's let's say assuming that this person has got active disease, it is important to treat because active disease has multitude of other effects besides pain, affecting morning stiffness, fatigue. Again, we see that in a lot of our chronic patients, spinal pain, and nocturnal back pain, which affects sleep, which ultimately can affect pain as well. So once we've done that, what I tend to do is I change to a different mode of action. And so what we're looking from here is that if you were to switch from one anti-TNF to a second anti-TNF to a third anti-TNF, outcomes tend to be not as great. So in this particular slide, we're saying that 54% of patients responded to your first anti-TNF, then they switched, and then they switched. And you're seeing, the response rates aren't so great. So unless there is a contraindication, the general guidance is that what we should be doing from these guidances, we should probably be changing to a different MOA after your first biologic. So if you would choose IL-17 first line, you'll switch to a TNF inhibitor or a JAK inhibitor and so forth. This is just some data showing with secukinumab that it worked. This is after TNF inhibition. It works very rapidly, and you've got long-term, it's sustained for at least 5 years. So just focusing on this whole concept of difficult to manage axial SPA. These are criteria that have just been released this year, and all 3 criteria must be present in a patient with axial SPA, which has been diagnosed by a rheumatologist. And these are the 3 criteria. So number 1, treatment according to the ACE-ASULAR recommendations, and failure of 2 or more biologic or synthetic DMARDs with different mechanism of action unless there is a contraindication to that. You have to have insufficient control of signs and symptoms of axial SPA as defined as 1 or more of the following: high or very high disease activity, so ASDAS greater than 2.1, signs or symptoms suggestive of active disease, so CRP and MRI abnormalities, rapid radiographic spinal progression, and well-controlled disease according to the above-mentioned points, but still have axial SPA symptoms that are causing a reduction in quality of life. And the third point is the present signs and symptoms are perceived as problematic by the rheumatologist or the patient. So just other considerations in difficult to manage axial SPA. And I mentioned depression earlier on in my talk, and I just want to focus on this. This is a study of 742 patients, and participants with moderately severe depression at baseline had significantly poorer responses to TNF compared to those with none throughout the whole follow-up period. So if you look at these actual slides, so you've got here moderate to severe right at the top and no disease at the top, there's a significant difference. And at 6 months, the difference in BAS-2 score was quite significant, over 2 point scores at 2.2. Moderately severe anxiety is associated with a 59% higher rate of treatment discontinuation than those with none. But this is the most, I find, fascinating thing. And 71% of participants with moderate to severe depressive symptoms did not have a documented diagnosis of depression. So what you must look at is your patients. Majority of our patients won't be diagnosed with depression. So you'll be the first to probably say, well, this is a bit unusual, and then do the appropriate scorings or refer accordingly to make sure that they don't have depression. So depression is very prevalent. It's definitely very prevalent in our axial SPA patients. Fibromyalgia, sort of mentioned to you, we know that those patients with fibromyalgia tend to have worse outcomes in their BAS-DI scores than say patients who don't have fibromyalgia. And this slide will show you that if you look at your fibromyalgia patients there, they start much higher, they do improve, but they still are quite high. And so if you were to see that patient say, oh, look, they've still got very active disease, they've got scores of over 4, so we must switch their biologics. No, it's probably because it's for various other reasons. The noisy plastic pathways are in effect, whereas these are non-fibromyalgia patients and they go into nearly disease remission, they do. Smoking, I sort of mentioned this yesterday as well. So I looked at the data about smoking. About a third of the population in Pakistan are smokers. So this is a really important thing. The smoking is not just about axial SPA. This is in all our autoimmune rheumatic diseases. And we know that those who have never smoked, treatment adherence tends to be much, much better in non-smokers than those who have ever smoked. And in axial spondyloarthritis, your response, your BASDI 50% or a 2-point improvement is significantly greater in your never smokers than those who have smoked. So it's important, and part of our treatment protocol in our Axial SPA is to refer them for smoking cessation as well. This is the slide I sort of mentioned yesterday as well, the overweight. I looked at the data as well. In Pakistan, over 25%, 25 to, I think it varies, 25 to 30% of the population have a BMI, it's not great, of over 25 and under 30. And the outcomes tend to be worse in those cohort of patients who are overweight or obese. And that's something you need to keep in mind when patients are not responding to treatment. So encouraging weight loss in our overweight patients. A few more slides left. The other thing that we don't really look at is what about social determinants, the hidden inequities, access to care barriers, so geographic distance to specialist services, so patients coming from, from far away, from Northwest Frontier, having to come down to the city just to get their treatment. I'm just using Pakistan as an example. That it's much more challenging to treat those patients. Limited availability of biologic therapies, certainly this is the issues that we have in Pakistan. Also, what about for individuals? The financial stresses affecting treatment adherence. You have to pay for your medication, and that is quite a big challenge, and why they're not doing well. And one of the key things with anyone with autoimmune rheumatic disease is educate them about their condition. And if you actually have barriers to education, for self-management becomes a lot more challenging in that cohort. The overall approach to our patients should be multidisciplinary, where I believe you get better management, more effective management, especially in our difficult to manage AxSpA SPA. You have a rheumatologist, a physiotherapist, a psychologist, specialist nurses, social workers, and we're doing much better at working very closely with our colleagues, our ophthalmologists, our gastroenterologists, our dermatologists as well. Something that wasn't really happening over 5 years ago, and it's something which is much, much better now. So, just a few more slides. The complexity of difficult to manage Axial SPA demands individualized treatment strategies that extend beyond standardized protocols to address each of the patient's unique constellation of challenges. Comprehensive assessment important, shared decision making is important, targeted intervention is important, and continuous monitoring is important. The key principle here is treatment success should be measured not only by traditional disease activity scores, but by meaningful improvement in patient-defined outcomes, including function, quality of life, and personal goals. And my last slide, managing Axial SPA effectively in the 21st century demands that we move beyond the traditional biomedical model to embrace a truly comprehensive approach, recognize its complexity, implement holistic assessment, foster collaboration with our colleagues, and empower the patients. So I believe the future of Axial SPA care lies not in treating the disease, but in treating the person living with the disease. Thank you.
Thank you so much, Dr. Hasan, for that insightful talk.
Our next keynote speaker is Dr. Katy Leung, Senior Consultant at Singapore General Hospital and Associate Professor at Duke NUS Medical School, Singapore. Today, she'll be presenting on APLAR Psoriatic Arthritis Guidelines. This session will provide practical insights into evidence-based recommendation for the diagnosis and management of psoriatic arthritis. Please join me in warmly welcoming Dr. Katy.
Thank you for the kind introduction. I'm really grateful for the Pakistan Society of Rheumatology to invite me to this talk. So today, apart from getting a difficult topic, difficult in the sense that it's not rocket science, and then another difficulty is at this time of the day where everybody, the stomach is filled and keeping you awake, I'd like to take this challenge. Let's see how I do this one. Okay, this is my disclosure. So I think everything starts with the why. Why are we doing all this guideline thing where there are already quite a bit of guidelines over there? There's a GRAPPA guideline, there's ACR guideline, there's EULAR guideline. But why are we doing another APLAR guideline? So when I think about it, that is, we are sitting now in Asia where 40% of the global population is resident in, together with us, and then we are pretty special people. We have different patient demographic and epidemiology. So data from Singapore as well as UK is telling us that patients with psoriatic arthritis, the South Asian has worse disease. They have highest prevalence of enthesitis, highest family history. They are worse, and we don't have a guideline for us. And in Asia, we have different socio-economic development and surely political and cultural difference. And worst of all, the healthcare system is less developed as compared to the West. In most places, we are lack of an insurance coverage, and the national security program is not that good. As a matter of fact, is that a lot of our patients are paying the biologic treatment and expensive treatment out of their own pocket. So when I think about all these, I think we have to put the people together, the stakeholders, the healthcare providers, and let's see what is the best evidence and what we can best serve our people. Okay, the people is really the heart of what we do, and then we have to, development of guideline is that you need to get the right people on the table. So then we set up a working group, we have a steering committee, and also we get a working group together. I think the APLAR SPA Special Interest Group is a very good portal that where we can start, because where we have all the countries together and we have members from all countries. So with these special interest group, we call out to get people interested in it. So we also need to set rules so that we are not excessively including people from one country and excluding people from another. So we decided that we only include one person from each country, and we invite that person to bring along a junior member from the team to come up with us. We have been having difficult time because there are many people who come to us say that I want to join, but we have to stay put because we are trying to make sure that distribution of the working group is equal among all the country, and we stay put throughout the whole project to make sure that is important. And then we also love to have other specialty involvement. We have 2 dermatologists by nomination, and we also have 2 patients, one from Hong Kong and the other from Pakistan. We're very happy to have them to enrich the perspective of the guideline development. So for the countries that do not have a SIG member in the SPA group, we write to the president of that country to nominate people. So we also want to have a more buy-in from our experts. So we invited each participant from each country to nominate 5 people. So we have an expert voting panel as well. We are grateful that we received the SIG funding from APLAR to make it possible. And of course, really grateful to the all the sponsors. So we decided that we need a structure to develop the guidelines. So we decided that we use the grade. So once again, the people is at the center of everything. There is evidence synthesis phase, and also there's a recommendation phase. I know that this is boring, but then bear with me. I just give a bit of moment to guide you through the process in case that you want to embark on your guideline development. There is a good framework. And for those who are reading guidelines, you probably know the process, how it has been done. So in the evidence synthesis process, the people are the one who put up the research question according to PICO. PICO is population intervention outcome, comparison and outcome. So we generate the synthesis, but the evidence doesn't mean that it is recommendation. It all go back to the group of people to discuss and come up with the recommendations. So the great approach is like this. So randomized control trials start with high quality of evidence, 4+, whereas observational study start with low quality of evidence. And then there are some guidelines to guide you through if there is increase in evidence or reduce in the quality of evidence. So from evidence to recommendation, they cut it into 4. So as either for or against. In each of the for or against, they have strong and weak. So this is a summary table. So we get up the evidence, so which take into account of the quality of evidence that judging around the benefit and harm. But high level of evidence doesn't translate directly into strong recommendation. So it comes to the working group again, and there is a lot more judgment to take, including value, preference, resource, equity, access, feasibility, all the difficult stuff before that we can get to the recommendation. There are several implications of these kind of recommendation to different people. So for the patient, if a strong recommendation means that most patients would want that course of the treatment. Whereas for clinician, if it is a strong recommendation, majority of the patients will be benefit from that course of the action. So for policymaker, if something is strong recommendation, these are the things that can put into policy. But I love this implication is some of the time that when reality and when the evidence is not that matching, and your policymaker might not be thinking the way as the industry or care providers would love to provide, then it is something the guideline or recommendation might be playing some role in persuading the policymaker to make necessary change to the policy so that we make the world better. So we decided we have several things in the recommendation, back to the PSA recommendation. So this is slightly more than what I conceptualized initially when I embarked on the project. So we decided that we should have some principle of management, and we should go to the efficacy of drug in the people. So we decided that we focus on 3 groups. The group with naive to treatment, the group that has been exposed to conventional DMARDs, and then the group that is refractory to treatment. We decided on class of drug instead of individual products. And then the outcome, because of the not a lot of manpower within the group, so we decided to make it simple. So we put the peripheral as 1, axial as 1, skin, physical function, and adverse event. But later on, we decided that we should look into axial domain. So we have another axial group. So we also think about it. We also need to look at the extra articular manifestation, including uveitis and IBD. So we have another group. So then we think about that we should focus also looking into metabolic comorbidity. So we have another group. And finally, we think that, tuberculosis and hepatitis B is so prevalent in Asia, we should have a little bit of thought about it. So we have another group. So totally we have 6 groups. So we divided our work into 6 groups. I'm really grateful. I really need to highlight this slide because everybody, I'm really grateful to the group leaders who take the lead to look into thousands of papers and come up with the evidence for voting. And if you look into it, there's not a lot of people in each of the group. I'm really grateful that we have patient partners, and then we have dermatologist involvement. So at the end of the day, we come up with the principle of management. So the principle management, we think that we don't need to look into evidence. We just need to look by common sense and also look into what is the best clinical practice. We then review all the existing guideline of recommendation and we draft them down into concepts. And we ask our members if there is any missing concepts that we have been missed. And then we vote. So I think this principle of management is, it's not rocket science, but those are important things. We have to state clearly what are the goals of treatment. Our goals of treatment is really to improve the lives of people living with psoriatic disease. And we emphasize shared decision-making with the patient. And then we emphasize regular assessment of psoriatic arthritis in different domains. Treat to target is really important. And we need to consider the comorbidities and extra articular manifestation. We also encourage multidisciplinary care and also emphasize early diagnosis. And for the main bulk, we have 16 statements. So we had 2 Delphi exercises to get consensus. And we also get it to the expert panel, which is 90 experts from all around the Asian country. I think the Delphi exercise, we have been very familiar with it, but it's important because a lot of time when you are in a meeting or a webinar, then your opinion might be dominated by a few voices. But then it's through the Delphi exercise that people will have equal voices. We all voting in an anonymized way so that we don't know what you vote and I vote. So people opinion can subsume and get a consensus out of them. Rest assured, I'm not going to tell you all the 16 statements as it has been published in the paper. So I just bring you to some highlights where the difficult part is. So first of all, we strongly recommend methotrexate as a first-line treatment if people considering DMARD therapy. And we conditionally recommend sulfasalazine and all the other DMARD. So we do have a very difficult time. We have a lot of argument and discussion. So because the level of quality of evidence to support methotrexate in other DMARDs is really low, but we consider that it is readily accessible for many of the countries, and we have been using it for the longest period of time. And we don't think that there is a lot of harm if we try methotrexate or other DMARD first before we go on to biologic and some other treatment that would lead to disastrous results. So if we follow the treat to target approach well, we should be fine. Just get a deep dive into the evidence that we are looking at why I say that is so low. So if you remember that the MIPA trial that is a long time ago, around 200 patients, is a larger trial for methotrexate. And you can see that it really doesn't show methotrexate is super. Of course, you may say that, oh, the MIPA trial, they use so low a dose of methotrexate, 12.5 mg. But it is as it is. We look at evidence, it is. So then the evidence is really very low. But at the same time, we also dig into observational studies. So you know observational studies start with a low quality of evidence, but they are still evidence that we could have lend an eye on it. So we have 4 observational trials at that point of time. Of course, we might have more now. So, but then you look at it, this is only the methotrexate monotherapy arm. Then an ACR of 20 of ranging from 40 to 60 is not too bad. And the MDA rate of around 20 to 30 is not too bad. If in the first 3 months or 6 months you start somebody on methotrexate, achieving the result of ACR 40, 50, then half of the patient is already on the good route. And then the other half, if they are not responding, then you move them to something else. But at the same time, we take into account, say, for example, the CMPSA trial, which is a huge trial, 800 people. And then these are people with very early psoriatic arthritis, mean duration of 3.2 disease, and more than 50% have less than 2 years. And then they are randomized to methotrexate, combination of methotrexate and etanercept. And you can see that anywhere there is an etanercept, the outcome is much better. So for people who have early psoriatic arthritis, methotrexate alone cannot compete with TNF. So we look into smaller trials by Van Mens and also the Goddard trial. It gives you similar result. Whenever you give TNF, comparing to methotrexate is much better. So we do have a good evidence to show that if we start treatment early and aggressively, they lead to better outcome. So as a result, we conditionally recommend the biologic as well as check for patients who are naive to treatment. There is high quality of evidence. We have a lot of discussion whether we want to strongly recommend or conditionally recommend. We resulted into conditional recommendation because we understand the accessibility issues around biologics and JAK inhibitors in the Asian Pacific region. If you look into this, that I'm trying to show you that whatever class of medication that you're giving a patient, they have similar efficacy to the joints. And head-to-head studies are telling us that interleukin-17 versus TNF blockers, they're pretty equal in their efficacy to joints. So that's why we conditionally recommend everything equally. Now, coming to the difficult topic, we are conditionally recommending the use of JAK to patients who are naive to treatment. Although we recognize that there is no current data to support the use of JAK in DMARD naive patients, and JAK inhibitors also carry some cardiovascular risks as demonstrated in the rheumatoid arthritis patient, not directly psoriatic arthritis patient. But we understand that there is strong evidence of JAK in DMARD experienced patient. And we also understand that there is generic JAK around many places in the Asian countries. So with a lot of limitations with biologic, this is something that we could possibly help our patient to select the good drug and get them into remission. So of course, we would advise with a conditional recommendation, then it need the physician and the patient to discuss and a lot more patient shared decision-making process to be done before you give the drug. So for the others, at the cardiovascular management, we decided we have to screen them. And we have to take them into account, and also the metabolic syndromes. For tuberculosis, of course, screening, but there isn't any good data to show that an IGRA-based test is better than the MT2 skin test. So we recommend equally, at least you have some kind of screening is good enough. And then for hepatitis B, at least you need to screen them, at least with the HB-SAG. So that's come to big picture. So we have the APLAR recommendation for PSA. So we have the overarching principle, treat to target, ongoing assessment, shared decision-making, managing comorbidity, and also multidisciplinary care. We had it for different domains, the peripheral domain, the axial domain, and extra-articular. So we had it for different group of people, treatment naive, DMARD exposed, and also biologic experienced. So we recommend methotrexate strongly and other DMARD conditionally, and then biologic conditionally. For people who have exposed to a conventional DMARD, as shown here, and then switching to another mechanism of action. For the axial disease, it's pretty similar to axial. And then, ladies and gentlemen, I'd like to conclude here. We have gone through an overview of how the guidelines is developed. I hope that it helps some of the juniors to understand what is guideline. So I presented the first Asian Pacific treatment recommendation for PSA. So we put people in the integral call of the guideline development. We have wide representation from all the APLAR countries. And we have participation from rheumatologists, dermatologists, and patients. We have comprehensively reviewed the literature, and we acknowledge the diverse across the region. We have thoroughly discussed and come to these statements, and we have some external endorsement from the regional expert. So I hope that this provides a good guideline for managing our patient with psoriatic disease. Thank you very much.
Our next keynote speaker is going to be Professor Dr. Tuncay Duruöz, professor at Marmara University School of Medicine, head of Department of Physical Medicine and Rehabilitation, and head of Rheumatology Division in Istanbul, Turkey. We welcome you, sir.
Dear chairs and dear colleagues, I would like to express my deep thanks to organization committee and especially to Professor Ahmed Sayed for inviting me this very distinguished rheumatology meeting. I'm very happy to be here, which I feel here home country or my brother country. And I'll talk about the late diagnosis in axial spondylarthritis and developing call to action. You know very well axial spondylarthritis, the clinical features were explained by Professor Hasan very well before. And it is chronic autoimmune progressive disease, mainly involving spine and sacroiliac joints, but at the same time, it may have some peripheral involvements and some inflammatory bowel disease, psoriasis, and uveitis can be seen with axial spondylarthritis, which increase the total disease burden. And roughly the percentage and prevalence of the axial spondylarthritis is 1% globally. This is ASAS classification criteria, which we use now, and this will be presented in ACR next week, and it is the revised classification criteria for axial spondylarthritis. And its sensitivity and specificity is better than the previous one. And I hope this new criteria will decrease the duration of delay in diagnosis axial spondylarthritis. And axial spondylarthritis, the disease starts somewhere here with some stressor factors, you know, and we can realize this this part of the disease by MRI. But for sometimes we realize and we diagnose here, sometimes here, and sometimes here. If it is very important to diagnose the axial spondylarthritis early time to prevent the deformities of handicap deformities for the patients. And there is no universal accepted definition of diagnostic delay in axial spondylarthritis, commonly defined as the time interval between the patient's first symptoms and the confirmed diagnosis of axial spondylarthritis. And diagnostic delay remains a significant challenge to effective disease management, contributing to increased morbidity and mortality. Diagnosis within 1 year of symptom onset is very important in recent literatures. What are the consequences of the delay? And it is associated with clinical, economic, and humanistic burdens. Specifically, patients experiencing diagnostic delay tend to have higher disease activity and functional impairment, increased direct and indirect health costs, greater risk of work disability and psychological distress. From the patient's perspective, diagnostic delay leads to significant emotional toll, fosters mistrust in the healthcare system, and negatively affect work, relationship, and mental health. And timely referral and diagnosis are crucial as early intervention is linked to improved disease outcomes and a reduced risk of radiographic progression. Why the delay exists? Low awareness among primary care, one of the reasons, and misattribution as mechanical pain, delayed referral to rheumatologist, limited access to imaging and tests. There are some challenges in primary care. For example, the rarity of inflammatory back pain. Back pain resulting from AxSpA is a rare cause of a very common symptom because inflammatory back pain is about 5% in all back pains, and it is not very common for primary care physicians. Misconception is important also, and persistent myths such as axial spondylarthritis, predominantly male disease, lead to under-recognition of the condition in females. It changed in the last decade, but it was very significant in before last decade also. Limited healthcare professionals, knowledge and awareness, and lack of specific biomarkers, complex diagnosis, there are no pathognomonic features to diagnose, and suboptimal healthcare practices, short consultation times, poor communication, unclear referral pathways, all these can lead to delays in diagnosis. And high healthcare utilization, patients frequently consult with multiple healthcare professionals before go to rheumatologist. Patient experiences for the diagnostic delay, emotional and psychological burden, feelings of disbelief, dismissal, frustration, desperation, depression, and distress due to prolonged diagnostic journey. They don't want to go doctor before because of these symptoms sometimes. Perceived invalidation. Patients often feel they must fight to be referred to a specialist. Sex-based differences. Females experience longer diagnostic delays, higher disease activity, and worse psychological outcomes, and lower HLA-B27 positivity. And physician bias contribute to misdiagnose or inappropriate referrals. These are of patient side for diagnostic delay. There are some systemic and educational gaps also. Primary care pressures and need for trained first contact practitioners, and lack of awareness of national referral guidelines, need for support tools. These are systemic and educational gaps for diagnostic delay. In this study, the 64 studies reported in this systemic review and meta-analysis, they excluded studies which recruited less than 2 years of diagnosis, because of all these 64 studies are diagnostic delayed studies. The mean delay is 6.7 years worldwide, and it varies by region also. And diagnostic delay related with lower education, absence of extraarticular manifestations, and younger age of onset in this study. This study is factors associated with diagnostic delay in axial spondyloarthritis, impact of clinical factors and social vulnerability. And patients recruited from electronic health records from December 1990 to October 2021, according to modified New York criteria and AXSpA criteria. And diagnostic delay, duration of back pain symptoms reported at the diagnosis form also. And social vulnerability index for each patient assessed. There were 555 patients, 63% of them are male, and diagnostic delay, the median is 3.8 years here. And according to this study, related to shorter diagnostic delay, is related with peripheral arthritis and older age at symptom onset. And related to longer diagnostic delay are ankylosing spondylitis at diagnosis, history of uveitis before diagnosis, and higher social vulnerability. You can see the statistics of this study also. And in another study, early diagnosis of axial spondyloarthritis among patients with chronic back pain using a clinical screening tool and referral strategy. And it is important, if patients screen their symptoms, if it is axial spondyloarthritis or not, to make early diagnosis also. And the lack of timely referral these patients to rheumatologists is a significant modifiable factor contributing to the diagnostic delay of axial spondyloarthritis. The usefulness of a self-referral strategy was assessed using a clinical feature-based screening questionnaire, single-center prospective study with chronic back pain patients. A tool, the name of the tool, consisting of 3 questions pre-screen and 8 questions screening questionnaire, was distributed to patients via the patient's communication portal and university Facebook page. And patients with affirmative responses on all 3 pre-screening questions and 3 or more questions on screening questions were eligible for the study visit. And the clinician's judgment was considered the gold standard for the diagnosis. And 86 patients completed the study, and the sensitivity and specificity of the questions demonstrated considerably variable. There was low moderate agreement between the patient responses on an online A tool and the corresponding physician confirmed response. And the area under curve was 0.66, indicating modest discriminative ability of the tool to differentiate patients with AxSpA from those without. And because of that, this tool modified, and it will be presented in ACR next week also. And you can see here the screening questions. And in this modified study, they modified 2 questions and they add optional diagnostic questionnaires. With these modification, you can see here the area under curve increase with diagnostic criteria, increase to 0.93, and the old ones is 0.56, and new without this diagnostic criteria is 0.63. Because of that, it will be useful to screen patients maybe themselves, or we can distribute to patients who has chronic back pain, if it is eligible or not, to refer the rheumatologist. Trends in diagnostic timing and clinical features of axial spondylarthritis by sex and clinical subtype. A multicenter cohort over 7 decades study. It's 791 patients with initial symptoms between 1961 and 2024 were analyzed. The sex distribution over time, before 1970s, all patients were male in these records. And female representation gradually increased, reaching 50% in the 2020. And diagnostic delay, it significantly decreased from 41.7 years in the 60s to 1.9 in the 2020s. And both sex experienced a similar reduction over time. For each decade, men and women had comparable diagnostic delays. And initial symptoms, low back pain, remained the most frequent initial symptom across all decades. Hip pain was more common in men than in women. And a significant improvement has been observed in the recognition of axial spondylarthritis in the recent decades, possibly related to the use of MRI as well as increased awareness of the disease. This progress has led to greater recognition of previously underdiagnosed female patients. And artificial intelligence is enter our lives very fastly. And there are some studies, and there are some continuing studies, also one of them in my department. And in this study, the ASAS MRI criteria focus on detecting bone marrow edema in the sacroiliac joints to classify axial spondylarthritis. Still, bone marrow edema alone has limitations because of false positives may occur after exercise or childbirth, while false negatives are seen in chronic disease. Structural lesions lack standardized classification criteria, and artificial intelligence-based imaging interpretation has emerged as a promising solution. This study developed deep learning model that integrates inflammatory and structural MRI features using a two-stage framework. And MRI data from 291 chronic back pain patients were analyzed, and 163 had AxSpA and 128 had non-specific back pain. And a bone marrow edema detection model, you know, the area under ROC 0.82, accuracy is 81.8%, and axial SPA classification model, see accuracy is high, and sensitivity and specificity is high degree also. And importantly, 6/9 clinically confirmed AxSpA cases missed by ASAS MRI criteria were correctly detected by the AI model, indicating its ability to capture subtle disease features beyond bone marrow edema. And the integrated artificial intelligence model effectively combines inflammatory and structural MRI markers to improve diagnostic performance and identify axial SPA cases overlooked by conventional ASAS MRI criteria, demonstrating strong potential for real-world clinical application. And in this survey was analyzed the records of the two hospitals from UK, and diagnostic delay change different in two hospitals. One is the Royal Free, other is Salford Care. but it's less than UK average diagnostic delay also. And healthcare professional, according to this study, 90% of participants consulted a GP before diagnosis. It's big problem maybe because they refer not early time to rheumatologists, and many participants also consulted other health professionals, physiotherapists, osteopaths, etc. And according to patient education, 80% of patients reported receiving adequate education at diagnosis, and 76% knew whom to contact during a flare. We need this patient educations also. Improvement over time, diagnostic delay have decreased for patients diagnosed between 2016 and 2021. And it calls for enhanced education and awareness among healthcare professionals and the public, better referral pathways, and the integration of axial spondylarthritis into rapid review clinics to reduce diagnostic delay. And this another study done by Axial Spondylarthritis International Federation. It is Patient Societies Federation. A comprehensive literature review was undertaken to gather global evidence on delays in AxSpA diagnosis. And ASIF held 2 virtual global forums convening patients, advocacy groups, researchers, rheumatologists, and other healthcare professionals from 23 countries across 5 continents to systematically examine diagnostic challenges across health systems and potential solutions. Findings from these activities were compiled into the new delay to diagnostic report. And these are the poor awareness of AxSpA, particularly in primary care services, complexities in diagnosis the disease, poorly defined referral pathways, insufficient patients, access to rheumatologists, and appropriate diagnostics are the problem in these countries. And after this study, ASIF published a report. According to this study, take the action and publish recommendation. The first recommendation is country-level healthcare leaders and decision makers should commit to joining national conversations about the current local state of AxSpA diagnosis delay and recognize the importance of reducing this through making it a healthy policy priority. And second recommendation is broader awareness campaigns needed. And third one is opportunities should be sought to establish collaborative-based approaches to addressing AxSpA diagnosis challenges. Fourth one is the AxSpA diagnosis is not straightforward. However, there are increasing examples of best practice in achieving early diagnosis. Healthcare leaders should raise awareness of the across national rheumatology and general medicine networks. And fifth one is the build stronger evidence base for others to draw on about axial spondylarthritis. How can diagnosis delay can be reduced? There are some key recommendations, my last two slides. And the point of patients launch public awareness campaigns to raise recognition of axial spondylarthritis and inflammatory back pain, develop self-assessment or auto-referral tools to guide patients toward early consultation, and point of healthcare professionals offer ongoing training for primary care, physiotherapists, orthopedists, and other professionals in AxSpA detection, promote use of standard referral criteria, enable decision support, detection tools in electronic health records to prompt referral. Accessibility is important. Also establish dedicated AxSpA inflammatory back pain clinics to improve access, expand telemedicine and tele-expertise service to enable remote rheumatology consultation. And a point of rheumatology, invest in research on new biomarkers, imaging and diagnostic criteria to reduce uncertainty, develop consensus guidelines to manage gray zone cases without clear objective signs, and cross-cutting and system level. System is very important also to reach the good, accurate diagnosis. Engage health policy leaders to prioritize reducing diagnosis delay, foster multi-specialty screening, for at-risk patients, implement monitoring and evaluation framework to assess impact and refine strategies. Finally, a multidisciplinary approach incorporating novel biomarkers and advanced technologies is essential to reduce diagnostic delay in axial spondyloarthropathies. Thank you for your attention.
Thank you all. Thank you for participation in this session. Unfortunately, we are short of time, so we will not be able to take any questions. However, it is strongly advised that those people who have submitted their questions can directly contact the speakers in the evening. Social evening and dinner time, and they can directly contact them. In the end, I would like to thank all the speakers, honorable speakers, who highlighted the various aspects of spondyloarthritis, and especially Dr. Leung, who came along with the APLAR, who highlighted the importance of APLAR region and the diversity of people involved in these regions, and the need for having a separate guidelines established for treating and managing this thing. Thank you all.
Thank you. Now, I would like to request our worthy chairs to please come on stage and present token of appreciation to our speakers. First, I would like to invite Professor Dr. Ahmed Abogamal to the stage. Now, I would like to invite Dr. Katy Leung to the stage. Next, I would like to invite Dr. Mehmet Tuncay Duruöz to the stage. Also, I would like to thank Dr. Hasan Tahir for his today's talk, as he has already received his conference memento in yesterday's session. Thank you. Now we would like to request Professor Nigat Mir Ahmed and Professor Sumaira Farman Raja to come on stage and present token of appreciation to Dr. Shazia Zamurad.
With that, we'll now conclude the session. Thank you so much to our chairs and our speakers.